welcome back. Hope you all had a good lunch break, and we're cruising along with our afternoon here. Today, the next talk, we're going to speak about hips, and we have Dr. Stephanie Wong is here. Dr. Alan Zhang is quite sick and has no voice, so Dr. Wong agreed to step up and take over. She will actually be giving his talk, but they do very similar things in practice, so it should go fine, and she should be able to field any questions that were directed at him. We can redirect to Dr. Wong. And Dr. Stephanie Wong has been with us for a few years here at UCSF. She did her residency training in orthopedics here at UCSF, and then left for a year to do a sports medicine fellowship in Chicago and came back to work with us. So we're very excited to have her. She takes care of hips and does surgery and treats patients with femoracetabular impingement and all kinds of hip disorders, as well as she works on shoulders and knees in athletes and generally active people. So we're excited to hear this talk from Dr. Wong. Thank you.
Thanks, everybody, and I hope you don't mind me standing in for Dr. Zhang. And thanks so much for the introduction, Dr. Wingfield. So go ahead and get started. No relevant disclosures for this talk. So just a quick refresher in terms of anatomy of the hip. So we think of the hip joint as a ball and socket that sits towards the bottom of the pelvis. The socket we call the acetabulum, and then the top of the hip is made of the femoral head. The labrum is a soft tissue structure, which we'll show you in more detail in a few minutes, that sits on the corner of the socket and kind of runs as a soft tissue bumper around the acetabulum, and it serves as a stabilizer for the hip joint and also contributes to the suction seal of the hip. The joint is covered, like all joints in the body, with articular cartilage, and so we'll go through during this talk kind of why are these structures important. What are we doing nowadays to try to help preserve these structures in our young active patients? And we're happy to take any questions at the end. So when we think about what exactly are we preserving, there's a couple different structures within the hip that we want to talk about today. The first one being the articular cartilage. So this is the smooth, hard cartilage that lines all of our joints. This allows the bones to glide over each other with really minimal friction. And you can see here a picture of the left hip. This is an arthroscopic image with the hip on traction. So you can see the head is pulled away from the acetabulum, and then you see a labral tear over there on the far right, that soft tissue bumper that sits on the edge of the acetabulum. So when we look at the articular cartilage, normally it should appear like this very flat white surface. That is normal. Microscopically, it looks more like this. So the articular cartilage is very smooth, and I liken this to kind of almost like ice on a freshly Zamboni'd ice skating rink, okay? So that's how it works inside the hip, to low coefficient of friction, very few cells, and no significant nerve endings. So the cartilage has trouble, number one, regenerating because of the number of cells that are present, and does not really sense early damage because of the lack of nerve endings here. So we think this is important because arthritis is essentially loss of articular cartilage. So as you wear through the cartilage, then you get eventually bone-on-bone arthritis, where the two bones are actually touching each other without that protective layer, shock-absorbing layer of the cartilage. So we tell patients that when you have arthritis, that's basically loss of cartilage, and then we treat a lot of patients in this spectrum that go from kind of early cartilage softening all the way to severe cartilage wear arthritis. So as I just mentioned, arthritis we think of as destruction of articular cartilage, causes pain, deformity, as well as disability. And many times patients may ask you, why do I have arthritis? Why is this happening? And it's really kind of a multifactorial reasons for this, including age of the patient. So we know that the water content, the proteoglycans, do decrease as we age, so that puts patients at risk of cartilage degeneration. Weight can also load these joints more and cause earlier wear of the cartilage. Genetic factors are often in play as well, so I'll have a lot of patients tell me maybe they have an early onset arthritis in their 30s, 40s, or 50s, and they may say, well, my mom had a hip replacement, or my mom had 2 hip replacements before she was 60, and that to us is on the early side. Finally, activity level and overuse. So maybe you have, people who used to be athletes growing up, or maybe they're currently still very active. And these can all cause, issues to the cartilage. And when you put them all together, this kind of forms this perfect storm of patients that develop osteoarthritis. Separate from osteoarthritis, there are other causes of cartilage degeneration, including inflammatory arthropathies. So these are autoimmune conditions, including things like rheumatoid arthritis that can contribute to degeneration in the joint. Post-traumatic arthritis is a big problem, so we'll show you some photos of that in a moment. And then finally, avascular necrosis or osteonecrosis, where the blood supply to the femoral head is disrupted, can also lead to breakdown of the joint. So here's some, again, microscopic photos. This is what normal cartilage looks like. So you can see that there's kind of these interspersed cells. The cartilage surface looks nice and uniform throughout. And then we have these grades of cartilage wear that we call the ICRS. The acronym's not important, but essentially to say that when you go from normal to grade 1, you start to have softening of the top surface of the cartilage here, which you see most superficially at the top of that image. Grade 2, you have partial thickness cartilage loss. And then grade 3 and 4 is getting more towards where you have almost full thickness cartilage loss. And then at the very bottom of the screen there where you see that red line going across, that's actually where the subchondral bone starts. So you can appreciate how this patient has lost kind of their cartilage progressively. And so we grade the cartilage loss arthroscopically. So here are some images from inside a hip at the time of surgery. On the left-hand side is a photo of the femoral head. You can contrast the white, smooth, articular surface, which is the normal cartilage, to kind of that focal area where they've lost cartilage, and you can see that light pink underlying bone. So I think of the focal kind of chondral defects as kind of like a pothole on an otherwise smoothly paved road. Now, you can look at that in comparison to the photo of the severe arthritis on the right side, where you actually see almost exclusively bone exposed, and you just see those little white dots. That's the very, very little remaining cartilage left. So to be honest, most of us would not be inside of this hip doing arthroscopy because that's a contraindication to the procedure, as we'll go over in a minute. But just to show kind of the degree of change here in terms of loss of cartilage. What does this look like on radiographs? So here's an AP of the hip. And on the left-hand side, this is a normal X-ray. So we see a nice, open, symmetric joint space between the femur and the acetabulum. And if you look on the right-hand side, we can see complete loss of that space. So you have joint space narrowing. Subchondral sclerosis refers to the whitening of the bone. That's the bone taking on more load because it doesn't have the cartilage to cushion it. And then osteophytes, which are bone spurs, and you can see those kind of protruding out from different areas of the joint. So these are all classic radiographic findings for arthritis. Not specific to the hip, but we use these kind of descriptions all over the body, but this is what it would look like in the setting of someone with hip arthritis. Now, with end-stage arthritis, patients will have significant loss of motion, so they might describe that their hips feel stiff, and they might also describe some difficulty with certain activities that require hip mobility, things like doing stairs, putting on shoes and socks, or reaching down and touching their toes. They'll also have significant pain with moving and weight bearing, and you might see them using some assistive devices to try to offload that hip and decrease that joint reaction force. Again, this is all due to the loss of cartilage over time. So unfortunately, currently, we don't have a great way to regrow cartilage. Hip replacements, as seen in this image here, do work really well for end-stage arthritis, but we have to be a little bit cognizant of how old the patient is and what activities they like to do when we're thinking about a hip replacement. Generally, hip replacements we think last 15 to 20 years on average, and I tell people that means some hip replacements last longer, some don't last quite as long, and it depends on how you use them. So a lot of hip replacement surgeons might recommend to their patients to avoid impact activities such as running or jumping sports, and for some patients those are really important. So let's move on next to talk about some causes of inflammatory arthritis. So in contrast to osteoarthritis, in inflammatory arthritis, the immune system essentially attacks its own healthy cells. And this can affect multiple joints throughout the body, as well as other organs, the skin, eyes, and the heart. Common in patients kind of in their 30s and over, although can certainly have an onset before that. Some common forms of inflammatory arthritis include rheumatoid arthritis, and then we know that lupus also affects the joints as well. Disease-modifying agents have really revolutionized the treatment of inflammatory arthritis, especially in our field. So we used to see a lot of early joint destruction in early adulthood that would lead to either fusions or sometimes replacements, but nowadays patients are living longer with their own native joints because of these really important medications. So our goal for these are to try to help prevent cartilage loss, and a lot of the treatment is really medical-based. Now, another cause of arthritis is post-traumatic arthritis. So this is a patient who sustained a femoral neck fracture, which you can see here on the left hip. This was fixed with cannulated screws, but you can see how in the follow-up x-rays on your right-hand side that the head has started to collapse. So one of the issues with the femoral head is the blood supply can be disrupted with a femoral neck fracture. And when that happens, the blood supply to the head is lost, and that can cause the bone in the head to die and then collapse later. So you can see that screw is probably honestly intra-articular within the hip joint, unfortunately. This is another image of a patient who had a femoral neck fracture with a different implant for fixation, but you can kind of see here on the lateral how deformed and misshapen that head has become following the injury, and that's all due to the disruption of the blood supply. Finally, we'll talk about avascular necrosis. So again, this is interruption of the blood supply to the femoral head, which can cause cell death. So this can occur in a variety of age ranges. 20 to 50, we think about trauma, so just like we talked about with femoral neck fractures, medications can also contribute to AVN, including oral steroids. So I always ask patients about oral steroid use, chemotherapy as well. Chemotherapeutic agents can also contribute. Systemic conditions such as HIV or hepatitis, also, we've seen that for AVN development as well. Alcohol abuse is another common cause. And then for many patients, we don't know the exact cause, and we call that idiopathic. So when we think of arthritis, I think most of us generally think of a patient in the older population, right? Those that are 55 and older, maybe 60. But the goals of this talk are to review, is it possible to prevent arthritis from occurring in high-risk individuals, especially in those who are really younger and active? So how can we avoid them from going from their hip condition to getting a hip replacement at an early age? So this is a really interesting study done by Clohissy and his colleagues out of WashU in St. Louis, where they looked at why patients had arthritis, and they call this the kind of early arthritis, so patients that develop arthritis under age 50. So 9% were due to post-traumatic arthritis, such as a prior hip fracture, about 30% due to avascular necrosis, and then about 50% of the patients in this study were due to structural abnormalities in the hip joint, such as femoracetabular impingement or hip dysplasia. So we know that FAI can lead to issues in about 15 to 30% of the population, and hip dysplasia a little bit less common, maybe under 5% of the population. And ideally, when we think about hip surgery, we'd like to try to avoid hip replacement surgery in young patients due to the risk of them needing a revision over time and them wanting to try to stay active throughout their life. So our goals are to prevent the worsening of cartilage wear and trying to help preserve the lifetime of the native hip if we can. So what is hip dysplasia? So hip dysplasia, as many of you know, is a congenital condition that affects the structural stability of the hip joint. Essentially, the acetabulum is the issue here. So the acetabulum does not develop deep enough, and then the femoral head is uncovered. Severe cases often are diagnosed at birth, so on physical exam or with ultrasound studies, and can be treated from infancy with bracing and sometimes surgeries as well. These are associated with breech, deliveries, female sex, as well as a positive family history. However, we often see milder forms in our clinics for adult patients. So people that don't have any reported history of a childhood hip dysplasia condition, but when we get x-rays on their adult hip, we see that the femoral head is relatively uncovered relative to normal. So here are some radiographs of an adult patient, and you can see here that on both sides, probably right side worse than the left, that the femoral head is uncovered. And the way I think about it is the roof should extend and cover most of the femoral head, and you can see here how half of the femoral head over here on this right side doesn't have coverage from the acetabulum. And again, this is much more common in female than male patients. And we care about this because hip dysplasia ultimately leads to arthritis, and it leads to arthritis earlier than in patients that don't have dysplasia because the contact forces and loading is different. Additionally, these patients often will have labral tears or labral injuries, and that all kind of contributes to the degeneration of their joint. So what do we do to treat hip dysplasia in an adult? So if it's not identified earlier in their childhood or infancy and identified more when they're skeletally mature, then a periacetabular osteotomy is an option. And this is a pretty invasive surgery, but essentially involves osteotomies or cutting the bone to actually remove the acetabulum from the pelvis, rotate it over to give more normal coverage, and then fixing it with screws. So you can see this is a preoperative photo on the left side showing that the angle of coverage over the femoral head is shallow, so that's 11 degrees. Normal for your reference is over 25. Then on the right-hand side with the screw fixation, you can see how the acetabulum has been basically cut out of the pelvis and shifted over and rotated to give more normal coverage. Now, of course, with a treatment such as this one, there are some complications associated. So this study, also by the Clohissy group in St. Louis, reported 40% complication rate, about 10 with major complications, so infection, nerve injury, needing revision surgery. So these are not small procedures, but so I would say we just take these all into consideration when we're counseling patients. Now, if someone was to have something like a periacetabular osteotomy for hip dysplasia, how do they do in the years later? Does this prevent them from needing to get a hip replacement earlier in their life? So this was a study looking at the survivorship of those getting a periacetabular osteotomy. And at 10 years, it was about 86% survivorship, so 86% still had their native hip. And if you follow them out to about 20 years, it's about 60% survival. About 14 and 40% respectively convert to total hip replacements at the 10 and 20-year mark, which matches up with the survivorship numbers. And then doing a PAO in patients over the age of 40 is quite uncommon, but in this study, they looked at patients over the age of 50 getting a PAO, and they had the greatest risk for converting to a total hip arthroplasty. The thought being that probably their arthritis was to a stage where, doing a PAO alone probably wasn't enough to save their hip at that point. This is a study out of Chicago by Benjamin Dome and his colleagues that looked at patients undergoing both hip arthroscopy and periacetabular osteotomy together. So we do this procedure here at our Hip Preservation Center because we recognize that there are also labral tears that go along with hip dysplasia. And so we treat these patients both with arthroscopy portion to fix the labral repair and then the periacetabular osteotomy to correct their dysplasia. This study showed really positive outcomes, so 80% return to sport rate at 2-year minimum follow-up. And you can see the types of sports these patients played. It was really wide range, but that distribution is over there in the pie chart to the right. So overall, in terms of hip dysplasia, further studies are really needed to investigate different treatment methods for dysplasia, how to lower complication rates, how to preserve their native cartilage, and how do we ultimately get our patients kind of back to their normal function and activities. So in terms of the other diagnosis that often leads to early arthritis, we think about femoracetabular impingement. So some of this will be a repeat from my talk yesterday, but just for kind of completeness sake, FAI is abnormal bony anatomy that often will form during skeletal development. So this is extra bone either on the socket side, on the acetabular side, or on the femur side that causes cartilage and labral injury. So here on the screen, you can see two different forms of FAI. We have the pincer form on the acetabulum, and then the cam variety, which is on the femur. And you can imagine as the hip flexes up that these two bony prominences can cause the hip to impinge or pinch against the other structure as the hip goes up into flexion. The little black triangle next to the cam is on the corner of the socket there is the labrum. And so the labrum, I think of it as just the soft tissue bumper that's in between these two bony surfaces that gets kind of just pinched repeatedly, and that can lead to tears and then cartilage issues down the line. So our understanding of the hip labrum and FAI has really kind of evolved over the past decade or so. We now know that the hip labrum is a protective ring of fibrocartilage that helps with the suction seal and joint stability. Labral tears are very common in FAI, so over 95% of patients in this study showed that had FAI had labral and or cartilage injuries. As the mechanical impingement bumps up against the labrum, you can see how that can cause cartilage injury. So that arthroscopic photo on the bottom, the flap coming down is actually a flap of cartilage that's come off of the acetabulum. And the junction between the labrum and the cartilage is often where we see the most damage. The labrum, in contrast to the cartilage, the labrum actually has nerve endings. So when patients describe pain, they're usually feeling the pain from the labrum, not so much from the cartilage itself. This is an image intraoperatively of a right hip in an 18-year-old showing a full thickness labral tear. So you can see this probe here lifting up on the labrum, and where the labrum meets the cartilage, there's developed a tear there, and then the cartilage has started to peel away. So this is a relatively early caught condition, right? So the rest of the cartilage, as you look down into the acetabulum, looks normal. So if we're able to stabilize the labrum here and repair it up to the acetabulum, then hopefully this cartilage lesion and labral tear won't progress in the future. So as I mentioned before, the burden of FAI in the US population is about 15 to 30%. But I would caveat that by saying this is radiographic only. So not everybody with radiographic signs of FAI actually have symptoms. So it's really just got to be careful to correlate with their clinical picture as well. Almost 80% will have bilateral radiographic lesions. We think of a CAM being more common in the younger active male and the pincer being more common in like a 30s to 40s-year-old female. About 25% of FAI patients go on to have surgery on the bilateral hips or develop sometimes symptoms on the contralateral side. And then, what's really interesting is that this seems to be more of a disease of kind of modern humans. So this is a really interesting study looking at the anatomy of the femoral head and neck junction in ancient specimens compared to modern day humans. So the Libin group, as defined in this study, or Libin collection of skeletons, had alpha angles all under 50, which is our cutoff for a CAM deformity. So that's in the blue line there. So essentially, this condition didn't really exist in ancient humans. The Hammond-Todd collection is a collection of skeletons of more modern age patients, and you can see how the distribution's really widened, and then there are some patients in this group that are an alpha angle above 50, which would mean that they've developed a CAM deformity. And we think that this is the case because a lot of this seems to be a developmental problem. So as modern history has evolved, we've started to include things like recreation and sport into our society versus maybe historically those activities weren't commonly partaken in just due to kind of modern development and resources. So we really, been understanding this more in kind of a modern fashion. Looking at the prevalence of FAI in athletes, you can see here from these numbers from a variety of different sports at different levels that many, many athletes have radiographic FAI. And so, again, not necessarily symptomatic, but just on radiographs, do they have either a pincer or a CAM? So we think that this is definitely associated with the type of activity that patients do, especially during their development or adolescence. These are some really interesting natural history studies that show that athletes develop CAMs over time. So this first study the study by Agricola looked at pre-professional soccer players in the Netherlands. They got baseline x-rays on these athletes at age 12, only showing a small number of them that had a CAM deformity, 2%. X-rays 2 years later showed that 18% of them had developed a CAM lesion by that time. Similarly, the study out of the British Journal of Sports Medicine looked at 142 hips, and 73% of those developed CAMs over their kind of adolescence and into skeletal maturity. So we definitely consider this as a developmental problem. And FAI treatment in adolescence before skeletal maturity is a separate talk, but also a very interesting field of study. So in patients where FAI is not recognized in an early age, we know that FAI can contribute to degenerative effects of the hip joint cartilage. So again, Clohissy, who's one of the major leaders in our field, did this study looking at these patients under age 50. About 45% due to FAI, 45% due to hip dysplasia, 10% due to trauma or other causes. And you can see here, this patient has degenerative changes of both hips, worse on the left side, with joint space narrowing, osteophyte formation, and you can kind of see how, if this patient had x-rays maybe several decades prior, that you may have seen a CAM deformity, as you can kind of see on there on the right side, kind of that bump on the side of the femoral head. So we can see how that leads to arthritis. So I don't know all these sports references because Dr. Zhang made this talk, but I'm assuming that he's talking about these athletes getting hip arthritis after participating in sports for a number of years. But going on to kind of the clinical picture for FAI, so patients will describe primarily pain in the groin or anterior hip, as well as pain in kind of a C-shaped distribution. So some patients, even unprompted, will take their hand in a C shape and put it right on the front and say, like this photo here, say my hip hurts here. Often they'll describe pain with activity, sports. Pain with sitting is a very specific finding for FAI that we often see as well. And then on physical exam, when we assess their ambulation, some patients will have an antalgic gait. This can also, though, be due to other acute injuries or arthritis. And when we look at the gait analysis for a patient with FAI, we see that they have a loss of hip extension compared to normal controls. Finally, when looking at range of motion, arthritis causes global loss of motion, so stiffness in all planes, compared to FAI, where you get decreased range of motion primarily in the kind of internal rotation plane. So that's that positive fader, that flexion, adduction, internal rotation maneuver that we do. And then here's a picture of one of the other kind of leaders in the hip arthroscopy field, Dr. Thomas Bird, doing kind of the fader maneuver on a patient. So what do we do to help prevent this cartilage and labral injury? So the first step is trying to make sure we diagnose these in a timely manner. Unfortunately, it's actually really difficult to evaluate how the cartilage is on MRI. So one of the studies that we've been involved in with our radiology colleagues here is actually looking at some special sequences on MRI to try to help show us these cartilage issues earlier. So these are not used in clinical practice widely yet. These are mainly research studies. This specific one is a T1-row sequence, which looks at the amount of proteoglycans within the cartilage and can tell us about early cartilage wear or proteoglycan loss. And that's associated with the colors. So kind of the cool spectrum, so the blues and greens is more healthy cartilage, and then the reds and oranges are cartilage that has less proteoglycan content, or we think of as unhealthy or cartilage that is delaminating. So being able to detect these changes early and diagnose these in patients allows us to help treat them at an earlier stage. So the first-line treatment for all patients is non-operative. So this includes activity modification, so rest if they're having a lot of pain, anti-inflammatories. So I always talk to patients about how much anti-inflammatories they're taking. I often find that patients underdose it. They might say that they take, they've taken ibuprofen, they've tried it one time at 200 milligrams. So I counsel them to say, if you're really that sore, let's try a short course. Again, not something I recommend for their whole life or for months on end without monitoring, but just, can we try this for maybe 2 weeks and see how your hip does? So the doses kind of written here are closer to the therapeutic doses, of course, and then ice as well as physical therapy. And I do think that having adequate pain control and inflammation control does help people actually participate in the physical therapy exercises. So if they're too sore to do the PT, they're not benefiting from that either. And what do we do with our physical therapy protocol? So it's really focused a lot on glute and hip flexor strengthening. So on the top right-hand photo, you can see a photo of a clamshell exercise. This targets the gluteus muscles. Lots of core strengthening, pelvic stabilization exercises, iliopsoas stretching, as well as hip flexibility or hip range of motion. This study was a systematic review looking at physical therapy as an initial treatment for FAI. They emphasized doing active strengthening over passive, using a core strengthening focus, and then doing a more supervised regimen compared to unsupervised kind of self-taught programs. For patients that continue to have pain despite some of the anti-inflammatories and other treatments we've discussed, you can consider an intra-articular injection. These can be either ultrasound or fluoroscopically guided, either with steroid, with local anesthetic. Some also will try just local anesthetic alone for more of a diagnostic tool. And then some providers use kind of a toradol as an anti-inflammatory agent into the joint as well. This is a fluoroscopic image. The needle here on the photo on the left-hand side, you can see as that little kind of pinpoint black area. And then with the dye injected, then they follow that with the steroid so they know they're intra-articular. So intra-articular injection without image guidance is not recommended because the accuracy is really low given the location of the hip. And then there's also adjacent neurovascular structures that you have to be careful for. I also really like using steroid and or local anesthetic injections as a diagnostic tool. So in this study, 90% accuracy for diagnosing intra-articular pathology. And so you can use this for patients that have FAI, you can use this for patients that have inflammatory arthritis, AVN, or have osteoarthritis of the hip. The pain improvement is variable, so I have a lot of patients ask, well, how long is this going to help for? Am I just going to need to keep coming back to get them? Really depends. Some patients report weeks of pain relief, some report many months, so it just depends on the patient. What other types of injections are out there? So there's platelet-rich plasma, which you may have heard of before. Essentially, for those of you that aren't familiar, it's a regular blood draw. Then that blood is taken and centrifuged to separate the cells from the fluid component, and that fluid component contains growth factors and anti-inflammatory agents that we call platelet-rich plasma. There is no current evidence for using PRP within the hip joint. I tell patients that it's not going to cause any of the underlying anatomy, such as your cam or pincer deformity, to change per se. No real studies showing efficacy for hip FAI or labral tears. There have been some studies looking at it for hip arthritis. We think that overall PRP is likely safe because it's an injection of your own blood product. So barring low risks of things like infection, we think that doing an injection such as this is safe, but the question is it efficacious or not? These studies look at ultrasound-guided hip injection with PRP versus hyaluronic acid, and these are for patients with early hip OA. So again, no studies done on FAI or labral tears, but this is for early arthritis. There was no significant differences shown in this study for PRP versus hyaluronic acid. This is another study, again, a double-blind RCT. They included the Kellgren-Lawrence grades 1 through 4, which is just a grading scale for arthritis, so from very mild to severe bone-on-bone arthritis, so a wide range of patients with arthritis. And they did ultrasound-guided injections of PRP, PRP mixed with HA, or just HA alone. And then one of the weaknesses of a lot of the studies in PRP is they don't really specify what specific PRP formulation they're using. And then the different types of PRPs depend on the industry group that you're running the samples on. So there are leukocyte poor versus leukocyte rich forms of PRP, and that might make a difference in terms of how these patients do after. The hip outcome scores were better at the PRP group at 6 months, but when you follow the patients out to 12 months, no significant difference. And you can see here that in these studies, there was no placebo or saline control group or no sham injection group, so hard for us to say, So I share these results with my patients, and ultimately, if they want to try it, I think it's reasonably safe, but again, efficacy is a little bit up in the air. Now, what things do I generally not recommend? So a lot of patients come in asking about stem cell injections. There's a lot of clinics out there that are advertising these, and I'm a little bit cautious with these because I don't always know the exact source of the injection. For example, there are placental tissues, allogenic cells, fat-derived cells, et cetera. There have been some safety concerns as well with the FDA and the regulation of these types of clinics. Furthermore, stem cell injections, in order to get stem cells out of a patient, think of it like, a bone marrow biopsy. It's basically the same thing. It's, more invasive than doing a simple blood draw or doing a steroid injection. And we don't have a lot of data right now on whether these are efficacious. So just kind of caution there. Finally, if conservative treatment fails, then we think about hip arthroscopy, specifically for FAI or labral tears. So this is an image of hip arthroscopy, and essentially to do this procedure, it's somewhat similar to doing a knee or shoulder arthroscopy, but because the hip is such a deep, congruent socket, we actually have to distract the femoral head out of the hip joint and open up the hip space about 1 to 2 centimeters to be able to operate in there. Now, how do patients do when they're considering either trying physical therapy or surgery? There's been a couple studies out of the UK specifically, and they've randomized patients with FAI to either hip arthroscopy or PT. Both groups seem to improve, but consistently in multiple studies, it seems that the surgery group improves a little bit more than the PT-only group. Some of these studies seem to be correlated with the trends in hip arthroscopy. So in the past decade or so, we've seen, hip arthroscopy as a procedure grow in the number of procedures that are happening per year. So this is an administrative database study done by some of my colleagues, including Dr. Zhang, showing the increase in number of hip arthroscopy cases done in the United States. And you can see these increasing, up until maybe the past 5 years or so, where they've started to kind of level off. Interestingly, when you look at the types of procedures being performed, these are kind of a variety of procedures that we do inside the hip during hip arthroscopy. And initially, when we first started doing modern hip arthroscopy, a lot of the treatment was really debridement. So kind of like when we first started doing meniscus surgery. If it's torn, cut it out. We didn't have sophisticated implants on how to repair it, and we didn't know the data on whether repair or debridement was better yet. So a lot of these patients underwent labral debridement and chondroplasty, which is the majority of the procedures you can see there. Chondroplasty is basically just trimming away frayed or loose cartilage. And then you can see that the femoroplasty, which is trimming back bone on the femur, acetabuloplasty, trimming back bone on the socket, and labral repair procedures really started to be counted really only in 2011 or so, because before that, surgeons weren't doing those types of procedures. So I tell patients that, our data and outcomes really are from about the past 10 years or so. So this is a relatively new field in sports medicine. So what does it look like when we're doing an acetabuloplasty? So again, a pincer lesion is that kind of overgrown socket or extra socket. So this is a picture looking down on the right hip. The burr you can see here is about 5 millimeters in size, although it looks really magnified. And we take that burr and use that to trim back some prominent bone on the socket. And that's how we treat the pincer lesion. And you can see the labrum kind of just to the right of that, below that white soft tissue bumper. And we usually follow the acetabuloplasty with the labral repair. When you look at the x-rays after surgery, it's a subtle change, but you can see how this patient has a small area of bone there that's then been resected on the postoperative x-rays. So you can see that subtle change, and we think that this, in addition to all the other treatments we're doing inside the hip, like the labral repair in combination, will help this patient hopefully preserve their cartilage and labrum moving forward. Now on the femur side, what does femoroplasty look like? So this is a hip reduced, so off of traction. Again, same type of burr. We're using that to now trim back the prominent bone on the femoral side. And so we do this, and we try to tailor these procedures towards the patient. So if you don't have a pincer lesion, you don't get an acetabuloplasty. If you have a cam lesion, then you do get a femoroplasty. So here you can see I'm just trimming back that prominent bone using the burr. And then we try to move the hip around at the time of surgery to try to address this lesion in 3 dimensions. Postoperatively, you can see a really nice correction here. So that big bump that you can just imagine is bumping up against the labrum and causing it damage is trimmed back. And so hopefully that labral repair will be able to heal and not cause the patient's symptoms down the line. All right, so aside from the bony work, here's what a labral repair looks like. So once the top of the acetabulum's been cleared of soft tissue, then we place this anchor. This one is actually a 1.4 millimeter diameter anchor. So you can imagine these are really, really tiny, nice implants that we use to be able to repair the hip. Coming out of the anchor are these 2 stitches, and then we pass 1 stitch around the labrum, and then grab it from inside the hip joint, and then ultimately tie the labrum back up to the socket. And that's how we do the labral repair. So it's really a reattachment of the labrum back up to the acetabulum. So I know I mentioned before that we used to do a lot of labral debridement. So how do those patients do compared to how patients that have labral repairs? So interestingly, both groups do seem to improve. So 68% of the debridement patients with good or better Harris hip scores, but 92% of patients with good or better scores. So we think that both groups improve, but the repair group seems to improve more. This has been reproduced in multiple other studies. What's interesting in the hip is that there are kind of a couple level 1 studies, many level 2 studies, and then lots and lots of kind of single surgeon, single institution case reports or case series. So this is just a really interesting kind of field, a lot of potential research to be done here. So I think I showed you this study already, but this is the one looking at PT versus surgery for a group of patients, with the group getting arthroscopic surgery with a bit more improvement at final follow-up compared to the PT group alone. This was a study I also presented yesterday during my talk, but a different level 1 randomized controlled trial, randomizing patients to hip arthroscopy versus PT, and again, very similar outcomes. So at 12 months, the surgery group improved more than the PT group, although they both saw improvement. And then this study is an interesting study. This trial looked at hip arthroscopy in a couple of different countries, and they randomized the patients to either getting a lavage, basically kind of a sham type surgery where we're just pumping fluid into the hip and then we leave, versus an arthroscopic osteochondroplasty, so trimming back of any of the prominent bone. Both groups did have a labral repair, so really the difference in this group was either they had the bony procedure or they didn't. The outcomes were very similar, but there was a higher reoperation rate in the lavage group, probably due to not addressing the bony deformity. So we try to think of hip arthroscopy kind of being kind of this multifaceted approach where we'll kind of tailor it to the patient, and we try to address their hip conditions based on what they have at the time. So these are just for your reference, but some of the studies looking at hip arthroscopy outcomes, many studies looking at 2-year outcomes, because honestly that is the minimum that's required to publish in these journals, so you have to have 2-year outcomes. A couple groups with 5-year outcomes, and then a very small number of studies that have over 10-year outcomes for these patients. And again, that's probably been because we've only been doing this modern form of hip arthroscopy with the repair of the labrum for just over 10 years. In terms of what we're doing here at UCSF, we've been following our outcomes for all our hip arthroscopy cases in a prospective fashion. So we collect pre-op, 3-month, 6-month, 1-year, and 2-year outcomes. These are some of the outcome scores that we collect. So pain scores, general health outcomes, as well as hip-specific outcome scores. We have over 1,000 cases in our database now, and our average 2-year follow-up has been quite good at 82%. So we are looking, to gather more and more data to help tailor our practice and help guide decision-making moving down the line. So this was a study looking specifically at our database. So UCSF outcomes of about 130 patients undergoing hip arthroscopy for FAI. So when do they tend to improve? So this study showed that most patients improve within the first 3 months, But at 1 year post-op, between 1 and 2 years, we do see that some patients do end up improving. So I tell patients that even though I say that you can go back to all activities at 6 months, doesn't mean that that's your kind of ultimate improvement. I reassure them that with continued work with their PT and at the gym, we do see improvement up, at 1 year, and then also between 1 and 2 years for a small subset of patients. And then how do these athletes do when they get these procedures? So these 3 studies here show a high return to sport rate. So athletes returning to sport at about 80 to 90%. And again, I would say the limitation with a lot of our hip literature is you've been seeing kind of the same names, right, pop up over and over again. I'm talking about Bird, I'm talking about, all these authors, and it's really because it's a very small community of surgeons who do these surgeries, and then the people who have long-term outcomes is even fewer. So I think that, the next couple of years are going to be really exciting to see as we grow our hip database here, we can hopefully help to study outcomes as well and give a more kind of generalized look. But if I had to summarize, I would say that based on age, the outcomes do seem to be associated to be better when patients are younger and have these procedures. So patients between the ages of 18 and 30 seem to have the best evidence for doing this, doing hip arthroscopy. So over 85% success rate with short to midterm follow-up. Adolescent patients also seem to do quite well in the pediatric literature. As the patients get older, though, and I say this caveat that I'm over 30, okay? So, 30 to 49 age group, kind of mixed results, seem to do better, again, with younger patients. And then over 50 years, patients getting hip arthroscopy, unfortunately, most studies show worse outcomes. So higher complication rates, more reoperations, higher rate of conversion to total hip. And when they convert to total hip, they seem to convert early, like within the first 1 to 2 years, which is a huge bummer for both the patients and the surgeons. This study, done by one of my mentors out of Rush, Shane No, looked at the outcomes kind of demarcated by age group. So in the dark black bar, younger than 30, the next one 30 to 45, and then in the most light gray bar, age over 40. And you can see how the outcome scores kind of decline depending on your age. So these are multiple studies, unfortunately, showing that age is associated with worse outcomes after hip arthroscopy. And specifically, patients that are older that have joint space narrowing. So less than 2 millimeters of joint space showed an 80% conversion to total hip in one study. And then patients converting to total hips that were over 50 in various studies, about 17 to 20%. So again, we try not to do this surgery for patients that have arthritis or have early arthritis, and we try not to do this surgery on patients who are older than 50. So again, the kind of importance of early clinical recognition here. This is a really interesting Kaplan-Meier curve looking at a database study in patients defined by age. So at the top, you have patients under age 30, and then they kind of go by next decades as you go down, and with the highest kind of failure rates or survival issues in the patients that are 50 to 60 or over 60 getting this procedure. So at 2 years, about 15 to 20% of those patients are failing or converting to total hip arthroplasty. So the big question is, we know that having FAI can predispose you to developing arthritis later in age, but does treating the FAI at an earlier age help prevent arthritis? So we don't know for sure the answer, but some of the early studies do seem to suggest that doing FAI surgery, correcting the bony deformity and repairing the labrum does seem to improve cartilage health and improve patient function and outcomes. So Dr. Zhang was awarded one of the Young Investigator grants through AOSSM, looking at the effects of arthroscopic surgery for cartilage health. And again, this is using a specialized MR sequence that we use primarily for studies right now. This is not widely available for clinical use, but we use a T1 row and T2 mapping, looking at the cartilage. And again, use this to try to understand if our interventions are helping these patients keep their cartilage healthy. So this is an ongoing study, and we're really excited to see some of the results. So in conclusion, preservation of cartilage is difficult for many of the reasons I've said already. And ultimately, the treatment for end-stage arthritis is hip replacement surgery. In young patients, we think of FAI and hip dysplasia as the primary risk factors for early onset arthritis. And we always treat these patients non-operatively to start. So anti-inflammatories, physical therapy, and sometimes injections are my mainstays for treatment. And then again, caution that some injections we don't always know the effects of, especially stem cell or other type injections. I would be a little bit cautious with those. And then finally, for those patients that continue to have pain despite non-operative treatment, hip arthroscopy surgery is associated with really great clinical outcomes and return to sports in the correct patient population. So I'm really strict with my surgical criteria for these patients because ultimately I want them to succeed and do better after the surgery. And at this time in our modern arthroscopy time course, it's really unclear if we are able to prevent arthritis progression. So I tell patients that we're currently studying that, but if they're presenting to me now unable to do their activities or they have pain with daily activities, then we have a good surgery to treat that condition. These are the references, and we're happy to take any questions.
Is that working? Yes. Thank you very much. That was a great talk, and it's very encouraging to hear the results coming through return to sport and return to activity after hip arthroscopy, and we'll look forward to hear what's coming in terms of whether it prevents progression to arthritis or not, because that's kind of the big question. Do we have any questions in the room? Here, I'll bring the mic over for you. And then I have one from our virtual audience as well at the end.
Does hip stretching help with hip health overall?
Yeah, so the question is whether hip stretching helps with hip health. And I tell patients, I think that it's everything in moderation. So I find that a combination of stretching, strengthening, and a variety of different types of impact is kind of the best recipe for success. So I see issues in patients where they're only doing one activity, so only stretching or only flexibility work, and then I also see the converse where they do no stretching and they only do strength work or a lot of concentric activities. So I tell people my best advice is for a diversity of exercise. A diversity cross-training is really important, and I think stretching plays a huge role in injury prevention. So overall, I would say yes.
I know you were talking about that you distract the joint to do the arthroscopy. How do you reestablish the pressure, like the suction pressure again?
Yeah, that's a great question. So what we do in surgery is we strap the feet into kind of these ski boot-like contraption, and then we actually pull on the operative leg to distract the hip joint open. Do all of our work inside the hip, so that's the pincer resection and the labral repair. And then when we go to do the cam resection on the femur side, we let the hip off of traction. So all the force, we use a special table. We take the traction force, we release it, and we watch the hip come back into the joint. Sorry that we don't have a video of that here, but with the repaired labrum, it's really nice. You can actually see that suction seal be reestablished with the repaired labrum. And then while we're doing the femoroplasty, we're ranging the hip, moving it around to bring the cam lesion into our view to do the burring and resect it. So we can kind of watch the femur as it rotates in the socket. So great question, but we always check that at the time of surgery just to make sure they're not leaving with the hip partially distracted.
Okay, I have one question from the virtual audience. And this person says, I have yet to have a radiologist talk about seeing a cam or pincer problem on hip x-ray. What do you order to get them to evaluate it, or what signs do you look for on x-ray?
Yeah, so radiologists may not use those specific terms. So when we say pincer, they may state that to be over coverage of the acetabulum or an extra deep acetabulum. With CAN, they might say terms like decreased femoral head-neck offset, meaning that the angle between the head and neck is less than we would expect, so there's more bone in that area. So oftentimes they're describing similar but not using the same terminology as us. And for all my patients that are coming in for hip eval, especially those who have already tried some treatment, I always insist on x-rays because, like I said, we don't know if they have arthritis. I don't know if they have mild hip dysplasia. I don't know if they have a camera pincer, and I don't have x-ray vision. So I usually get an AP pelvis and then a lateral of the affected hip. There's a couple different laterals. I don't know if it's super important to know which one to get, but I would just say an AP and a lateral of that hip is kind of the radiographic images I would start with. All right, thank you, everybody.
All right, thank you so much.